So hello, everybody. My name is Amber Brown. I'm a marketing and sales associate with Sigvaris Group. And joining us today on this MOH Talk is Dr. Joshua Trock. He's the Director of Clinical Operations, Doctor of Physical Therapy, and Lymphedema Specialist at San Antonio's leading vein treatment center, Medical Vein Clinic. Dr. Trock is the director there. He is a lymphedema specialist with over a decade of experience, holds multiple certifications, including CLT LANA accreditation, RVT, and CWS. He developed the first home lymphedema treatment program in South Texas and has trained many therapists to serve patients throughout the region. So thank you, Dr. Trock, today for bringing us this very interesting topic. I will let you take it away.
Perfect. Thank you, Amber. I appreciate that. And let me share my screen. Okay. How does it look?
Perfect.
Awesome. All right. Well, first and foremost, thank you, Amber Sigvaris, for allowing me to speak on a subject that has really become very near and dear to my heart over the past year, as me being with a group of phenomenal clinicians here at Medical Vein Clinic have really dove into this subject matter and walking through individuals who have had pelvic vein compression syndrome and just the life change that has occurred in these individuals through proper identification and then treatment. And I want to be able to share that with all of you, because this is something that most likely, if you're an outpatient physical therapy lymphedema clinic, you will at some point run into, probably more recent or more prevalent than you actually realize. So just a little bit about me. I've been doing therapy now for going on 15 years. The first 10 years was dedicated to the world of in-home lymphedema, which is a lot of wound care and really complex patients. And over the past 5 years, being with the team at Medical Vein Clinic here in San Antonio, as we've expanded our services as well to not only treat superficial venous disease, but lymphedema, lipedema, and now pelvic vein compression syndrome as well. Here are my disclosures. And so we'll talk about our learning objectives. I have 5. It's probably going to be a whole lot more than that. And one just little caveat, I completely understand as we go through this, my slides are going to be very, very busy at some points, and I try my best to curate this down, but this is a huge subject, and I really want all of you to be able to grasp how all these things are connected. In addition to that, I also understand that this webinar will be available later on the MOH website as well as YouTube to be able to watch. And I'm going to strongly encourage you all to do that. So let's talk about the objective. So first and foremost, I want you to be able to recognize what is pelvic vein compression patterns and the red flags associated with it. Second, to differentiate pelvic vein compression from other things like lymphedema and other vascular pathologies. Third, to know when and how to refer for a vascular workup. Fourth, to understand vascular interventions and their implications of how they relate to therapy and how you plan your course of actions. And then finally, utilizing what is a proper intervention for these patients before, during, and after identification and treatment. So why does this matter to you? Well, in my opinion, pelvic vein compression is one of the most overlooked causes of things like unilateral lower extremity swelling, chronic pelvic pain, and low back pain, and particularly those individuals who are in a lymphedema, pelvic, or really just any physical therapy outpatient clinic. You're not only going to be probably the first time to see it, but you're going to be spending the most amount of time with the patient with the opportunity to identify it. And that's something that's even developed over the course of me developing this webinar, is speaking to individuals, therapists in various settings, and how they, just by speaking to them, recognizing that this may be a pattern of patients that they actually see on a fairly consistent basis. And let me show you that. So I've got a couple statistics for you. So first and foremost, there's some really good studies that show how prevalent this is. So this is from 2 studies that just had random CT scans on individuals, and they found that in 24% of adults, they have greater than a 50% left common iliac vein. So that's the vein we're going to be talking about primarily, compression, yet are completely asymptomatic. And also in a separate study, 66% have greater than a 25% compression on incidental CT. So this is just general population. And so this is pretty prevalent. Now, these are asymptomatic individuals, but in terms of the propensity of this challenge to the venous system, this is pretty prevalent. Next, in terms of the female population, which we're going to spend the most amount of time with, 25 to 40% of multiparous or women who have been pregnant more than once, age 20 to 45, have an anatomical variant, which is greater than 50% of that vein compression going on. Next, May-Thurner syndrome, which is another way of describing left common iliac vein compression, 78% of those individuals are female. And in regards to diagnosis, it's actually pretty later on in life, around 42 years of age. So I'm going to be giving you some numbers that are going to be hitting home over and over again because I really want you to remember that, along with these recognition patterns. So here you go. And we're going to be describing this as we go through the next hour. So one is unilateral left leg swelling. The second is abnormal ultrasound findings. And I totally understand many of you may not be familiar with ultrasound. We're going to spend a little bit of time on that, and you're going to walk away understanding it a whole lot better. Persistent pelvic symptoms, young to middle-aged women, those who have poor response to complete decongestive therapy, and then once again, multiple pregnancies. So we got to lay the groundwork. We need to understand the anatomy and pathophysiology of what's going on, particularly how the plumbing and blood flows within our body and the implications of when it does not do it well. So let's talk about this. So we've broken this down into 4 classical zones. So we have zone 1, 2, 3, and 4. So zones 1, 2, and 3 are the classical ones. The fourth is kind of an add-on just because it's more of an adjacent to what's going on symptom-wise. But the first is zone 1, and this is talking about at the kidney level for things like nutcracker syndrome, which I'll describe to you here in a little bit. The next are the zone 2. This is more of the pelvic region. So classically, gonadal, iliac veins, and then the pelvic plexus. Next would be a little bit lower. We're talking about the groin area, the gluteal, the inner and upper thigh. And then finally, zone 4 would be the lower leg veins, both deep and superficial. And so the hierarchy, and I have another slide next that's going to show this a little bit more in terms of functionality, is we are moving things from distal to proximal, from out to in. That is how this blood is going to flow. And as we're thinking about this, we think of all the escape points. So the one thing you need to keep in mind as we're talking about all of this is fluid likes to flow from high to low pressure. And when pressure is increased somewhere abnormally, it is going to find a way. And that's what's really going on here. So this is an animation I made that shows where blood is flowing. And once again, we're talking about from distal to proximal, from out to in. The whole goal is to move this blood to that inferior vena cava, your IVC, so it can return back to the heart and the whole system starts all over again. And so we've got a couple different routes. The main route is going up through the legs, through the pelvic, both the internal and external iliac veins, common to the IVC, and then a side route, particularly on the left side, which we'll spend a lot of time on, in regards to the ovarian and gonadal veins. So May-Thurner syndrome, this may or may not be something you are familiar with. It's something that I've known about over the past few years. We really don't get a lot of it in various lymphedema education, but we talk about it quite a bit in the vascular ultrasound world. And here's what it is simply put. It is compression of the left iliac vein by the right iliac artery. And this happens almost exclusively at the L5 level of the lumbar spine. And why does this happen? Well, as you know, we are not symmetrical individuals. Our IVC is almost always on the right side of our body, and our aorta and the subsequent vessels are on the left side. Well, when you have something having to cross, things can go bad. And that's basically what it is compression of that vein by that artery. Now, as this is described, this does not always happen this way. Sometimes you have the left iliac artery compressing the left side of the iliac vein. Sometimes there's actually both veins being compressed. There's definitely variations, but this is the classical definition. And it is not just pure compression. You actually have changes within the vessel by constant trauma. So you get thickening of the internal side, internal aspect of the vessel, as well as collagen depositions that also occur. And this happens in roughly 1/4 of the adult population have this going on, but are completely asymptomatic. And so this causes an outflow obstruction, both in terms of narrowing of the vessel along with external compression or narrowing of the tube. And this leads to high pressure within that vessel that has to be escaped somewhere, and it finds a way. Along with that, we get secondary reflux. So vessels that were not designed to handle that load eventually wear out as well. And so to put it simply, in terms of classic presentation for you, you're going to want to be looking at for individuals who have swelling primarily more in the left leg than the right leg, young to middle-aged women, let's say age 20 to 50, those who have multiple pregnancies, along with persistent low back pain or pelvic pain, oftentimes without really a source diagnosed. And they may or may not have a history of a DVT or an SVT. And their swelling is just like with the pelvic and back pain, idiopathic. And then unilateral varicose veins, for instance, if there's more prominent veins on the left side versus the right, once again, not always present because varicose veins can be hidden. If they're lower in the adipose layer by a couple centimeters, you're still not going to notice them, even if they are present. And then varicosities that are coming out of abnormal regions, so not the inner thigh, which would be off of the saphenous system, but those emerging from the groin, the pelvis, the buttock, sometimes even the low back. And then pain after activities, particularly intercourse or exercise or any physical exertive activity. And so I want to provide for you a new framework of looking at this. And this is something that is in the newer literature by removing older terminology, particularly the term pelvic congestion syndrome. That was removed or really overlaid by this framework, which we'll go into here in a little bit for a couple different reasons. One is it describes a symptom and not really a mechanism, which is particularly not helpful when you're talking about fixing the problem. If we're just talking about, let's say, swelling, well, that is a symptom. We need to understand why that is actually going on. In addition to it, it is inconsistently applied. A gynecologist may look at it completely differently than a pelvic floor physical therapist or a vascular surgeon or interventional radiologist. And then it also excluded what was going on distal. So the new framework really brings all these different elements in. And then finally, pelvic congestion syndrome sometimes falls into the category of, let's say, like fibromyalgia, where it was more of I don't know what else is going on, so we're just going to call it this. So let's talk about what does this actually mean. So the first that we're going to talk about are the symptoms. And so this is the way that you start to classify symptoms, anywhere from no symptoms to renal symptoms to different types of varicosities or claudication going on. The next would be varices. So these are noticeable veins somewhere in the body. Maybe it's higher up in the kidneys, maybe it's in the pelvis, the vulvar area, lower extremities. Once again, these are signs of what's going on and where we can retrograde back from there. Let's say it's coming out of the gluteal region. Well, that is different than coming out of the vulvar region in regards to what's creating it. And then finally, pathophysiology. So this is something where maybe it is happening from the IVC, maybe it is a gonadal vein, maybe it is because of obstruction, or maybe it's just because of reflux that developed over time. So this gives us a lot better of a framework at understanding what's actually happening. And this is going to be critical as we talk about the different ways that this happens. And there's going to be 4 that we're going to spend our time on today that really go over the mechanisms of why pelvic vein compression and its subsequent symptoms actually develop. So we'll talk about the first one. This is called nutcracker syndrome, where specifically on the left side of the body, much like with what's happening with the IVC and the iliac vein, where that left renal vein has to cross over the aorta before it attaches to the IVC. Oftentimes this happens anteriorly. There are variants where it happens posteriorly as well, but mainly all of us are going to be happening anteriorly. And why that is important is because there's an artery that comes off of the aorta right at that area that can compress that vein. And when that happens, it can back up into the kidney and cause renal issues, as well as it goes into the subsequent ovarian vein, which also can cause symptoms associated with it. And so here's a description of it in regards to how things flow from that initial compression. And when we talk about prevalence of this, just in terms of ovarian vein reflux, so reflux coming off of that renal vein, 44% of women who have been pregnant have it going on. And what's interesting is how worse it gets, the more pregnancies that occur. And so the difference between no pregnancies at 5% all the way to 2 pregnancies, 90%, which is quite interesting. And even in healthy adults, 72% have some level of left renal vein distension. And so in terms of symptomology for this, sometimes you'll have left flank pain or hematuria. It's actually not quite as prevalent. However, worse pelvic pain with standing, which is oftentimes misattributed to things like GI issues or musculoskeletal issues as well. And if you wanted to do a notation, this is how you would describe it. The next is the more classical May-Thurner syndrome, which is the zone 2. And as we've described, it is the compression of that left iliac, the left common iliac vein by the right common iliac artery. And when that occurs, we have compression, we have obstruction, we have changes both internally of the vessel as well as externally in regards to just this sheer compression. And I have a really good MRI that I'm going to show you guys so you have a better understanding of all of that. In regards to predominance, well, in terms of May-Thurner confirmed DVT, 92% happen on the left side. All that goes to show is how prevalent the left-sided compression is versus right-sided. And in regards to bilateral variance of the curve, 24 to 66% have significant compression on CT, as we've already talked about. And so where does this manifest in terms of general population? Well, once again, individuals with unilateral left leg swelling, pelvic heaviness, maybe or maybe not DVT, younger women, vulvar perineal varicosities, once again, may be present with or without a prior DVT. And this is probably the most important. And we have 3 case studies at the end that I hope you can stay on with me with, because it's going to really tease a lot of this out in reality of why this is important to differentiate between a lymphedema versus what's going on here in terms of the veins being compressed and having subsequent symptoms. Now, in our clinic, this is probably the most common that we see, which is a zone 3, which is a combination of both things going on, where there's something happening at the renal vein, the ovarian vein, gonadal veins, as well as that left common iliac vein. And when this occurs, your body is trying to find a way. I almost did the Jurassic Park quote, life finds a way. Well, blood finds a way. It's going to go one way or another. And it's trying to find release of that pressure. And this is going to go to either zones that cannot hold that level of blood, or it's going to be vessels that were not designed to hold that level of blood. And so this will then lead to things like that unilateral leg swelling, or you could have it on both sides, just more predominant on the left side. Sometimes DVT, sometimes not. Pitting edema can eventually develop, and typically that is more of a superficial venous congestion leading to a Phlebolymphedema type situation if this has not been caught early on in the process. Varicosities that are more in the groin or pelvic region, which is not always presented. Patients obviously don't like talking about these things, but they are very, very important. And I will also add, is I have a slide coming up here in a little bit on pregnancy. That does happen during pregnancy, but oftentimes goes away. And we're talking about a situation here where it does not go away after those first couple months postpartum. The symptoms worsen with things like menstruation, prolonged standing, obviously pregnancy. No family history or really no reason why they would have a lymphedema. Obviously, there's not a surgery or some sort of cancer diagnosis that one would think about that. And when we're talking about prevalence, 8% of premenopausal women have dilated pelvic veins and chronic pelvic pain. That's 1 in 10 individuals. And then 21% of premenopausal on CT will also show it. And really 30% of chronic pelvic pain is attributed to pelvic vein disease or pelvic vein compression disorders, which is quite prevalent. If you really think about this in regards to your population, just right away stratify younger females that have had multiple pregnancies. And now you start to see how regular this could be coming through your door in your clinic. Once again, here's that SVP notation. And then the fourth is post-thrombotic. So this would be an individual who had compression of that iliac vein, so the big tube bringing all that blood out. And what happens when you compress a vein? Well, blood slows down, and the slower blood moves, the easier it clots. There's also things like hormonal imbalances, as well as other medications and circumstances that can make a person more clottable. So this would be an individual who has had a blood clot. And I've got a really good slide coming up that will show you what happens and how we get rid of all of that. But basically, it damages the inside of the vein. It's called post-thrombotic syndrome. In addition, when that happens, and if it hasn't been caught early or treated early, you then get subsequent damage to the superficial vein system as well. By blocking the major highway of blood out of the legs, essentially everything else starts to break down because of it. In some individuals, the clot eventually resolves if it was clot early and they were on the right treatment plan. However, we have seen patients in our clinic that had no clue whatsoever that they had a blood clot at some point in their life. And so this individual would have more of a fibrotic edema, more of the classical lymphedema going on. They may even have a positive Stemmer sign, or if you're not familiar with that, that is a pinching off of the skin on the tip of the second toe, you can also maybe do the dorsum of the foot, but basically the foot is so swollen you cannot pinch that. Dermal fibrosis, things of that nature, also going along with the skin changes with that. In regards to prevalence of that, 20 to 51% of individuals who have a DVT in this location will go on to develop post-thrombotic syndrome. And there's quite a large and substantial amount of individuals, and this is from European studies that probably would believe it more larger in the American population for various reasons. And also, key differentiator for this is things like staining, lipodermatosclerosis, and more of that classical Phlebolymphedema type circumstance going on. So, in synopsis, who are more at risk? So, in terms of that nutcracker syndrome, one, they do have to have the anatomical variant for it, which quite a large amount of people actually do. However, it will worsen with each subsequent pregnancy. In zone 2, we've already talked about all those studies that show just in terms of the variance of individuals that have compression of this vein is pretty high in the general population. And then you start to layer on all the circumstances that will make it worse. Zone 3, once again, this is individuals that probably 8%. So 1 out of 10 women that fall into this category may have this going on, may be symptomatic, maybe not. They may have symptoms that are not experiential, so they may not have that pelvic pain, or at least pelvic pain that they are associating with what's going on here. Maybe they were told they have low back pain, or they have hip osteoarthritis that has a similar overlap, or maybe they have these varicosities that they're just not talking about. And then finally, the post-thrombotic patients as well. One key note for here in terms of pregnancy-related DVTs, just in terms of the general population of DVTs with May Thurner's, it also happens on the left leg, primarily 80% of the time. In regards to parity, pregnancies do matter. And so when you have individuals and you're screening for something like this, premenopausal, those with multiple pregnancies in that specific age range and have more of a predominant swelling in the left leg, definitely something you really need to be considering and ruling it out. So speaking of pregnancy, so here's how it amplifies it. So the first and foremost is just the compression that occurs in that region by having a human being growing inside of you. I have never been pregnant. I'm married to my wife who has been, and I've watched that whole scenario, and what the body goes through is absolutely remarkable to accommodate that. But you have to understand where that baby is growing at. The vessels there being posterior to it, well, will experience some level of compression going on. In addition to that, there's the hemodynamic changes where basically by compressing that vessel, particularly the IVC and the proximal iliacs, it is going to decrease flow. Well, flow still needs to move and it's got to go somewhere. So it's either going to go down the leg, it's going to go to the side up into the renal system, or it's going to go deeper into the pelvic system. In addition to that, through the act of pregnancy, upwards of 3 months postpartum, there are many factors that change, both hormonal as well as just general in terms of blood volume, where an individual is more hypercoagulable, they're more likely to clot. And this is parsed out in regards to things like left ovarian vein reflux, how much it increases after at least 2 pregnancies. One would believe it would increase even after more than that. And here's some good studies just on pregnancy and compression I wanted to throw in here as well as the most appropriate spot. One that I do want to highlight for you is that a study from 2017 that showed compression reduced nausea, dizziness, and improved quality of life in the first trimester by utilizing compression. All the patients we see here, many had developed their symptoms from pregnancy. It always baffles me why compression is not utilized more during pregnancy, particularly if there's any symptoms going on. So maybe you can make the difference for that. So clinical presentation, what this looks like as this individual is in your clinic. So let's talk about how we differentiate out things from primary, secondary lymphedema, chronic venous edema, and then pelvic venous compression. Now, first, can a person have all 3 going on? Absolutely. But as we are teasing these things out, we need to understand what more of the symptoms are that are going to push you in one direction versus the other. So the first one that I talked about in regards to this is the Stemmer sign. Is the foot swollen versus not? And so this could be a classical lymphedema, or it could be something that's even a post-thrombotic lymphedema or post-thrombotic syndrome that's going on. In regards to the edema, more fibrotic in lymphedema, a lot less and much more reducible in both venous edema and pelvic edema. Sometimes the foot is involved in venous edema when it's more of a lymphedema, typically not in venous congestion. Varicosities, much more prevalent, or large, more squiggly veins underneath the skin going on in definitely pelvic venous situation going on, definitely pelvic symptoms, as well as on ultrasound and imaging, you're going to see a lot differences, particularly on ultrasound. And we'll dive into each of these as well. So in higher risk populations, which I have belabored the point to show that to you up to this point, if it's really important to rule that out, keep it on your idea list of possible things going on, because obviously you can have more than one, but we definitely want to rule that out as a diagnosis. So let's talk about the individual symptoms that could be happening with these patients. So the first is that unilateral swelling, where it's worse on the left than the right. You can obviously have it in both legs, but predominantly you're going to have it more on the left leg. Disproportionate ultrasound findings, which I'll show you here in a little bit. Poor response to complete decongestive therapy, and then worsening symptoms in regards to standing, menses, pregnancy, things of that nature. Chronic pelvic pain of venous origin, aching, deep pressure, pain after intercourse, vulvar varicosities, symptoms worsening as the day goes on with activities, as well as you can even say, what did you used to be able to do but can't do now? As they describe those things, those are good ways to tease out how life has changed as these symptoms have progressed. Low back pain. I've had many patients come in and they've got the full workup, injections, all these sorts of things for low back pain, when lo and behold, it was actually the pelvic veins causing this. And this can even go into sciatic, SI joint issues, inner groin issues. So maybe individuals think it's more of a hip pathology going on, even some nerve involvement as well. So there's a lot of things going on in that region that can become involved. Even GI or urology. So feeling of having a UTI, but not having a UTI, urinary frequency and urgency, IBS type syndromes, postprandial pain or nausea. All these things can actually be related to this. And even autonomic, there's not any big studies on this, but there is definitely possibly some correlations in things like POTS, dysautonomia, tachycardia, headaches, and various other symptoms. And I have a slide on POTS, and I'll talk to you about why that could possibly be the case. And then the skin changes, whether it's brown staining of the skin, and like what happens in classical venous disease, swelling that worsens and worsens to more of a lymphedema as well, where you could even get recurrent cellulitis. So red flags. So first and foremost is changes on an ultrasound. Now, I know a lot of individuals are not doing ultrasound, but you may be aware of that. And I'll show you how you can utilize that. I think that's here in my next slide. Yeah, it is. Excuse me. And then that unilateral disproportionate left leg edema in that population that we've identified as much higher risk. Failing of compression. And this is really key. Of all the things that I want you to take away, this is super, super important. And that is individuals who have tried medical grade compression, like what we use here in the clinic, 20-30 compression for most individuals, is when they wear it, it makes their symptoms worse. And I will tell that to them when we're having our initial evaluation, is if you wear this compression and your pelvic, your low back, your symptoms get worse, you call us right away. Because if you think about it, it makes sense. We are pushing so much more blood volume into a compressed system. And so we're increasing that pressure in the pelvic region. So I would expect those symptoms to worsen. And then obviously the presentation of various varicose veins, not in a classical superficial vein pattern. So you have a combination of pelvic pain and leg swelling, particularly more predominant on the left. That should really start to get your antenna up to ask more of these questions in regards to other symptoms that may be going on. And then even if it's higher up, that more of a classical nutcracker syndrome, like pain in their left flank or blood in their urine, definitely refer for that as soon as possible. So all these symptoms can add up and they can be quite disparate, but that's why I'm trying to go all over this with you into all these different scenarios so you can ask these questions and you can develop that questionnaire in your mind of how to walk through that. Even individuals with fibromyalgia, IBS, where they've come in with a primary lymphedema diagnosis, to still ask about all of this, because lo and behold, the previous diagnosis may actually have been wrong or misdiagnosed. So I talked about imaging. So let's go into that now. So ultrasound, I No, in the physical therapy world, musculoskeletal ultrasound is becoming more and more prevalent, and I could not be happier for that. I think it is a wonderful diagnostic tool to utilize in a therapy clinic for uncovering what's going on. It is cheap, it is relatively easy to utilize, and you can use it with your physical exam. Well, I've reached out to individuals that teach on all this, and their ultrasound machines, not only can they have great images of musculoskeletal anatomy and physiology, but you can also use it to look at the venous system. Our ultrasounds here are designed for the venous system, but you can still use it to look at what I'm about to present to you. And that is what the blood looks like in that common femoral vein. And so the common femoral vein is that big tube that comes out before it goes underneath the iliac ligament that is bringing the majority of blood out of your leg. And when you look at it with ultrasound, we look for what's called phasicity. And there's an image of that here on the screen. And so a good way to look at that, it's like the tide. The tide comes in, the tide comes out. So just like with your breathing of your diaphragm, you breathe in, you breathe out. The blood will respond to that as it's moving because the venous system is low pressure. It will respond to that phasicity. In actuality, why blood can return back up is because of movement of the diaphragm. And so we would expect that to happen. We call it a phasic movement going on. However, if you use an ultrasound and you look at this region and you look for what's called continuous flow or non-phasic flow, where essentially it looks blunted, like it's not wanting to move forward, that is a very, very key indication that something is going on proximally to that vessel. And so just understanding this, the phasicity of the common femoral vein to if it is continuous, that is a really, really important thing to look at, particularly if you're looking at both sides and this is happening on the left leg, but not happening on the right leg. Really should get your antennas up. And so how to use this in your practice if you do have ultrasound looking for that phasic flow, comparing to left to right. Obviously, if they've maybe had a DVT rule out, maybe not. These sorts of things are on that exam. If you have access to those things, if someone had gone for a previously rule out, and a lot of patients with unilateral leg swelling will end up in an ER, an imaging center for that, those would be important things for you to understand as you're looking at this imaging studies. All right. So in terms of hierarchy of imaging, the first and foremost is a lower extremity duplex ultrasound. So this is what we do all day, every day here in the clinic, looking at both the superficial veins, the deep veins, as well as how the blood flows in the pelvis to give us an understanding of what's going on. To go from there, if you really wanted to interrogate the pelvic system, you can do that in two ways. One is looking through the iliac veins. The patient would come in NPO. They wouldn't have food or water that day. So there's nothing in the intestines. And you can go and look at the vein, or you can do a transvaginal ultrasound to see what's going on with the adjacent pelvic vessels. Next would be a CT or an MRI, which really outside of an interventional diagnostic is going to be very, very good. But even within that, not our CTs and MRIs are looked at the same, as well as you have to have, particularly on the MRI, which is a little bit more inclusive at finding this, you do have to have a very specific protocol for that. And then finally, IVUS or intravascular ultrasound. And this is something that I have an image from, but it is absolutely phenomenal in regards to understanding what's going on within that vessel. So let's go over an MRI. How we understand this and just orientating you is an MRI, as this person is here, is like a slice of bread, what we're showing you today. So on this screen, the person's head is behind us, the feet are towards us. The right arm would be on this side over here. The left side would be on the aortic side as well. And what we're looking at right now is the liver on the right side. I put some arrows on here for the aorta and the IVC. So let's see if we can see my scroll. Here we go. So here we got the aorta right here, and we have the IVC. And what I'm going to be doing is imagine these are slices of images, and we're going to be moving towards the feet. And so imagine you're inside of that vessel and you're just going along with it and seeing what happens to it. So as we're walking here, pause this. Okay. So we're going to be moving down towards the feet, and now we're following that vena cava. And now what's coming up on the bottom, those are the kidneys right there. You see the aorta. And one thing you're going to notice right here is how flat that IVC gets. It's quite remarkable how it changes shape. But what we're going to be most concerned with as we come down, we're going to be getting towards that L5 vertebrae. And right here, that aorta is splitting. Now remember, it is actually moving proximal. So these are actually more of a convergence, but it splits into the right and left iliac arteries. And now that IVC has to compress over. And right here, you see how that iliac artery is absolutely smushing that vein against that anterior aspect of the vertebral body. And then it even comes over and gets hit by the left. So there's both the right and the left iliac arteries compressing that vein. And so imagine how much pressure is being put, everything distal to that, trying to get through that region. And then once it gets past, it'll open back up. It is at this point much more lower pressure because it's not able to accommodate all of that. I'll show you a next image. Now, this is a CT scan of another one of our patients. And what I want to show on this is this patient has a stent inside, which I'll describe here in a little bit what's going on with that. But I want to show you how far back this is. All right. So I'm going to get my image right here. Okay, perfect. So this is where the stent is. You can see it lights up right here and how far down it actually is in regards to where the pubic and the ischium is, or sorry, the ilium. And now we're going to be moving up, and you see how it comes up and then it curves in. You can see inside of it. You're right. We have a sagittal view, so we can see inside of it. And right here, look how close that is to that L5 vertebrae. It is right on top of it. I don't think a lot of people really appreciate how compressed it can get against that vertebrae, as well as how posterior. So you can see if this is an involved vein, how compressed that vein is and how you can develop that low back pain going on. All right, so intervention. So I didn't want to touch on, although you're not going to be seeing this, but you may see patients who have had this happen, and that is in presence of an acute DVT. So if a patient comes into your clinic and you suspect a DVT, please get that patient an ultrasound as soon as possible. At a vascular clinic like ours, at an emergency room, at so anyone that has the capacity to do that, because that can be quite serious in terms of developing both a pulmonary embolism, which can kill you, as well as very serious post-thrombotic syndrome. So basically, once that patient is identified with the clot, we have quite a few patients that have come in with clots that we then identify as having some sort of proximal compression. They have to go to the hospital. And what happens next is called a thrombectomy, where there is a removal of that clot. They will use IVUS, they will remove the clot, and then they will balloon open and stent it to remove the May Thurners that is causing the compression on that vein, thus causing the blood clot from there. Afterwards, they're typically on anticoagulants. And what I wanted to get to is what this actually looks like. So if you're eating lunch right now, I hope this does not bother you. But this on the top left there is what a clot actually looks like. I created an image of it to show it much more. But this is a right-legged DVT that went all the way into the IVC and also involved the left iliac. So you can see how large that clot is. And so this clot is removed, then the compression would be stented, and the patient would be in anticoagulation afterwards, both in regards as part of the having a blood clot, as well as what is typical standard of practice after having a stent placed in. And so let's say the non-thrombotic May-Thurner syndrome, what happens here? Well, here's the stepwise workup. So first we do an ultrasound and we want to see what's going on. We're looking for that physicity. We're looking for larger junctions, where basically what means is that there's a widening of the veins that are attaching to that system due to negative pressure or backwards pressure going on. The vessels will enlarge to accommodate. So we're looking for things like that, along with history and symptoms and all of that. So to build up this case. The next, ordering a CT or MRI to see exactly what's going on in regards to compression of that vessel. Next would be an IVUS with venoplasty and stenting. And then for post-stent care, and there's really not a huge consensus on this, but generally some level of blood thinner, maybe it's Plavix for a couple of months and then an aspirin afterwards, utilizing compression if there is still things like swelling and other things like that going on, maybe superficial venous disease as well, which is quite common. And so what this means for you as a CLT, a therapist, is asking the questions before and after. So before stenting, talking about the swelling, seeing if it's resolving or not, seeing if their symptoms are getting worse. And then also avoiding aggressive MLD, any abdominal things in that iliac region, if that is going on, not hoping to not exacerbate the pelvic symptoms because, well, that compression has not been fixed yet. Same thing. And I'm going to bang this drum. If compression is making the symptoms worse, you can stop wearing the compression because it's a positive diagnosis, but definitely need to have that patient seen by the appropriate vascular professional. You may be able to try a knee-high compression just to resolve some of the distal swelling. And then also documenting what's going on with that, because as that patient then comes into a vascular clinic like ours, that history is so important to have all that written down and to understand that. And then after stenting, understanding what's going on in regards to, is that stent still patent? Meaning, is there a thrombosis inside of it or not? If it's an older stent versus a fresh one. Coordinating with the vascular team, are they on anticoagulation? Do they have any contraindications going on? Compression therapy, they will need long-term maybe even physical therapy going on for the pelvic region. And we also, if there's superficial venous disease, there may need treatments for that as well. Once again, coordinated that with your vascular clinic. And as I just mentioned, absolute need for pelvic floor physical therapy afterwards. I have a whole slide dedicated to this coming up. So this is a C-arm. This is a video x-ray machine. This is what we utilize here in our clinic as we are treating this condition. And I'll walk you through this. So right here, this is the catheter with a balloon stent about to be deployed right here. So it's all along this region right here. And what's great about a C-arm is it has the element of time. So, a standard radiograph, it is just a single image. Here, we can actually see as things move, both in terms of whatever is inside, like a stent or a wire, or as we shoot dye in there, and we can see how things are flowing. So let me show you this. All right, so we'll walk through this. So you can see at the top there, the stent is starting to deploy as they're pulling back. So right up here, you can see that stent deploying right there. And on that previous CT, you can see how long it actually was. So we have that stent being deployed. Typically, they will have ballooned this first. And now they're going to shoot dye. So now we can see here that the dye is flowing through the way that it should. Prior to this, when they would have shot dye, if there was compression going on, you would see it stop there and then go over to a gonadal vein or down into a pelvic vein or some other outflow. And then next, you can see it flowing there through this stent. And then here's an IVUS. And what we're going to do here is, so the IVUS catheter is up here and they're going to be pulling back. And so here is that catheter. We're inside the lumen of the vessel right here. And so this is like Magic School Bus. We're with Miss Frizzle. We are walking through here in that school bus. We're going to be going through that tunnel. And so as they are pulling back right about here, we are now in the stent. You can see that right there. The change of color is a lot brighter right there. So they're pulling back through that stent. They're making sure that is open. It's not compressed. Everything looks good there. So that's IVUS. I think it's a phenomenal tool. It's great seeing these images. So the next thing is compensation versus uncompensation. As I've shown you on multiple studies, individuals will have this type of vein compression going on, and it can either be compensated or uncompensated. Compensated basically means that the body is handling it and things are still happening. It's just not in a point where it's bothering the patient, where once it becomes uncompensated, then the patient is much more likely to actually voice what's going on. Much better to catch them before that, because we're obviously stopping this things from worsening. But it all matters the timing that they come to clinic, as well as these questions that we're asking. So the whole goal here is to rule out that pelvic pathology with or without symptoms going on. So uncompensated, these veins, these deep pelvic veins or ovarian veins, are just growing to compensate for that. So this one, they're going to have the pelvic symptoms going on. They may or may not have swelling disproportionate happening, but that pelvis and that whole bowl of pelvic veins are going to be enlarging. And then for that left ovarian vein, reflux, they're compensated for it. Hypertension, maybe they'll have varicosities, maybe they'll have like primary varicose veins going on, what looks like that. Ultrasound is very good at teasing this out as well, because we can see what it's attached to. If it's a uncompensated common iliac vein obstruction, classic venous claudication, left leg swelling, all these things that we've talked about previously. And then if they are compensated, same thing. Swelling may be modest, but there's going to be more pelvic varicosities going on. Fluid has to find a way, matters how robust the body is at finding those outflows. So the bottom line here, whether the presence or absence of pelvic symptoms does not necessarily rule out pelvic venous pathology. So these are questions you keep in the back of your mind until proven otherwise. So core morbid conditions. And see, this is our classic patient. This is the individual who has Phlebolymphedema. Individuals who have had venous disease progress to a lymphatic overload or lymphatic dysfunction due to that excessive venous hypertension, typically other comorbidities as well, where that swelling starts to happen because the lymphatic system is basically taking over for the venous system not working well, where you get that hard sclerotic tissue, brown staining of the skin, lack of leg hair, sometimes ulcerations and cellulitis if it's allowed to progress. And this is quite prevalent. Good research by Steve Dean, I know him quite well, over at The Ohio State University, showed that the primary etiology of lower extremity lymphedema in the United States is untreated venous disease at 41.8%. And then as well, and there's newer studies that show this is actually more prevalent than just lymphoscintigraphies, that CVI, once it starts to develop and it reaches what is called a stage 3 in terms of the SEEP score, has a lymphatic dysfunction going on. So really, if a person has swelling at the end of the day and complains of tired, achy, heavy legs, they have a lymphatic overload starting to happen on there. And the odds ratios of these things happening. So 4 times higher risk of leg pain versus varicose veins alone when this is going on. 7 times higher risk of leg edema. And this is all with pelvic venous disease adding fuel to that fire. So we're not just talking about superficial veins not working well. Now we're talking about an obstruction higher up, leading to higher pressure down. Same things with leg heaviness. So a 5 times higher risk. So as you have patients that have leg pain, that have leg edema, appreciable or not, because the tissue can hold a lot of fluid before it really ever notices it. These are things also you really need to consider. And the AVLS, which really guides a lot of venous and lymphatic guidelines, state that once a patient reaches a SEEP3 or they're getting persistent edema, there is a lymphatic dysfunction. You want to treat it like that as well in regards to interventions. And the whole goal is to stop it before it progresses to that irreversible stage of lymphedema. So, whole thing, catch this early. So, why this is important for me in particular in our clinic is, well, we live in South Texas and there's going to be a higher incidence of this for a variety of reasons. There is more venous disease in the Hispanic population, particularly in older individuals ages 40, 60. And that happens due to a combination of things like a higher BMI, more fertility and higher levels of pregnancies, more sedentary occupations and lifestyles, high risk of diabetes. I didn't touch on lipedema, but I want a little bit, but more of a prevalence of things like lipedema and obesity. So there are a multitude of reasons, and this may be your region as well in terms of individuals or just that person that fits into this category that are going to have a higher risk of things like venous disease, pelvic venous compression, as well as a potential lymphedema going on. And that parity risk in terms of multi-parity, 90.6% left ovarian vein reflux after just 2 pregnancies. And then obesity, when an individual has a BMI that reaches 40, they are on the cusp of what's called oil obesity induced lymphedema. Once you hit 50, it is guaranteed that's going to happen. So if you can imagine an individual that has all this going on, and then you factor on the obesity and then all the sedentary lifestyle that typically comes with that, is only going to compound things that are going on. And so lipedema, and this is a whole conversation in of itself, but we do find it more prevalent in individuals who have been diagnosed with lipedema. And there's not a direct causation, but I'll walk you through this. So a big study that came out of Switzerland last year showed that 86.2% of individuals who have been diagnosed with lipedema also have concurrent superficial venous disease. 92.1% have also all these comorbidities that also will lead a person to potentially have pelvic venous disorder. And then in terms of numbers, 10 to 11%, although this is all over the map because there's not really a diagnosis code going on, so it's really hard to diagnose this, not a clear-cut criteria for it. Some numbers are up to 18 to 20%, but I think that's going to be much more regional when that happens. And individuals will have this going on in terms of onset for 15 years before they ever receive a true diagnosis with that. And this is just some things in terms of general population versus lipedema of things going on like venous disease, obesity, and some of these other disorders that may or may not be part of the pelvic vein compression going on. And so what's harder in these individuals is they may have varicose veins, but you don't see them because of the lipedema tissue, or same thing with the swelling. And so that's why it's important to, if you have an individual like that, I'm of the understanding you should have some sort of venous study going on, like what we do here in our clinic. We're looking at deep, superficial pelvic flow, all of that in one shot to ensure that that is what's going on and direct care appropriately from there. Same thing with utilizing things like MRs and ultrasound studies as well. So I mentioned this earlier, POTS. This is a very interesting one. And one of our case studies touches on this as well. So if you're familiar with POTS, POTS for orthostatic tachycardia syndrome happens typically in younger females where complete abnormal blood pressure regulation, where things decrease in regards to that pressure, and dizziness and inability to do certain activities. This is a just published study by Brooke Spencer and her group in regards to what goes on here. So the first and foremost is you just have that mechanical compression, in that by compressing the iliac veins, there's decreasing the amount of flow going up. So remember, about 66% of our entire blood volume is housed in our venous system, much more obviously in the legs. And that's the challenging side, because that's the side that's going up against gravity as opposed to what's happening in our arms and our head. And so if you decrease the amount of flow going up, you decrease the preload into the heart, which means there's less blood coming out, which is harder for the body to regulate that in regards to change of position. So that could be what's going on in regards to just a pure compression. Their group and what her study talks about are also damage to the autonomic nervous system, or an impairment to it that happens in these circumstances, where you also have a dysregulation of the ability of the vessels to contract and relax in regards to change of position. But it is something that I think if you have individuals that have POTS, it would be a really, really good thing to also get them looked at in terms of their superficial venous disease, purely for just getting them into compression. As almost every patient that has had a POTS diagnosis, when we get them into good compression, a lot of times their symptoms actually improve. So just something to think about. And I put some statistics from her study on there as well that you can look through at a later time. So interventional strategies for this. First and foremost is chronic venous edema with pelvic reflux and compensated is a compensated disease. That's going on. Proceed with your therapy. Also post-stent, varicose vein edema, lymphedema, all of these things proceed, obviously doing them in conjunction with what's going on. And then things that you want to rule out first to reassess is the swelling, or a suspected May-Thurner's without, or pelvic vein compression without a vascular workup. You see these varicosities that have not been addressed. Maybe they have a prior stent and they haven't followed up with anyone as well. In addition, that wearing compression makes symptoms worse. And then if you know that the stent is compromised, or they have an active DVT or potential active DVT, or an SVT, which is a clot within a superficial vein, all those things really, really need to get that looked at. I will add on to this, if you are dealing in this world, if you're treating these types of patients, I would highly recommend having a really good collaboration with a vascular clinic that you can dialogue back and forth with, particularly for things like a blood clot. I'm the understanding it's a lot better to be seen at a vascular clinic that does this all the time versus an ER, which they're not the best at catching these things as well. All right, pelvic floor physical therapy. Just in my look as I'm preparing for this, and correct me if I'm wrong, but I do not think that this sort of thing is brought up very much in the training for pelvic floor physical therapy interventions. So if you go back from there, how much of this actually happens both in our lymphedema certification or just general therapy training? I'm assuming it's not quite high, but as I've shown you with these numbers, you have quite a few individuals coming through your clinic, either symptomatic or asymptomatic, with this going on, that you should consider. And so what a stent cannot fix. So that pelvic venous hypertension over time will cause damage, both in terms of the vessels as well as the mechanical change that occurs, whether it's through pain or through just the damage of having multiple pregnancies, central sensitization, weakening of the pelvic floor muscles. Vascular interventions are going to fix the flow, but not what's going on in that region from a neurovascular and neuromuscular standpoint. So I truly believe that after every single intervention for this, pelvic floor physical therapy is probably a really good idea to go through. And here's some great studies. I don't want to spend too much time on that, but there is a lot of really good literature showing the necessity of that in these individuals. We do our best when patients have gone through that and have gone through treatment to get them with a good pelvic floor physical therapist as well. And so when to refer after we've addressed the compression and done a stent and embolization, well, a whole bunch of things here. But basically, if an individual has needed to have an intervention, odds are they're going to need some level of intervention, whether it's for bowel bladder training, whether it's through just a weak core, unable to stabilize for certain activities. All those things absolutely necessary. So when and how to refer from you, either as a lymphedema therapist, pelvic floor therapist, physical therapist, occupational, wherever, as you're encountering these individuals. We'll go through these things again. So that left leg edema, changes on ultrasound, varicosities, history of DVT, pelvic pain, low back pain, not responding to treatment, or pelvic pain or low back pain, not responding well to treatment. And who do you refer to? Well, this goes back to my previous statement. It's a really good idea to have a clinic in mind, and that could be typically vascular surgery, interventional radiology, working together like what we do here in our clinic. A phlebology, there's not really a phlebologist. Those are individuals who have gone through, who've been boarded through the American Venous Lymphatic Society, who's a diplomat of those things. Those would be really good individuals to go to because they then understand the lymphatic and the vascular system to a much greater degree. Sometimes gynecology, if they understand this, how to guide patients through this, and I put some language on there for you in regards to how to dialogue potentially what you think might be going on with that, as well as how to write a referral note. That dialogue and that communication, we're very big on that here. We love going back and forth with therapists, particularly because you are spending the majority of the time in the healthcare continuum with that individual. You're more likely to grasp and gather more history and symptoms and how things have responded or not responded. We're almost done, guys. So hang on. We got 3 case studies, and these are patients from our clinic. I've been involved in all 3 of their care. So the first one is Abby. So she thought she was crazy, and then we found the source of was actually going on. So her history. So she was 62-year-old female. She was a physician's assistant at a local hospital, has her BMI. She was on HRT. She had a history of prior left vein stripping, and then she had a preemptive bilateral mastectomy. So high risk of cancer. She had previous vein disease, which is why she had the vein stripping. And then she's on hormones, which can potentially make a person more clottable. And so when she showed up at our clinic, she was talking about left leg swelling. We use a device here called a lymph scanner. And what that basically does is it shows how much fluid is in the tissue, which is vitally important for us because edema, once again, can be hidden. It cannot be, sometimes it's not obvious. And so this is essentially like an analyzing a sponge and seeing how wet it is. And for her, it was much more swollen in the left leg than the right leg. We do an ultrasound. We looked and saw that there was dampened flow coming out. So we ordered an MRI. Challenge here was the MRI was all backed up. And so when she had come into the clinic, the left leg was significantly more swollen. And so what we did was, well, we put her in for our IVUS and cath lab to go and take a look. And yeah, she had absolutely compressed vessels going on. But the challenge here, and this was what was different, is when that stent was deployed, and it's done through with balloon, or you try to balloon that area up, it wasn't really moving too much. So although the stent was deployed, there was something externally compressing that was not that was abnormal to the vessel. And what we ended up finding, because she still got the MRI, was she actually had a ovarian tumor compressing on that. And so we walked her through that with other individuals that could identify it and treat it. And the whole moral of this story was, yes, she had a pelvic vein compression going on, but it was actually a tumor that was compressing it. But because we had found it and she was able to get treatment so early on, she was able to get that fixed. And then we were able to help her out in terms of the swelling and all these other things going on. But this is an example of something where there was a pelvic vein compression going on. She had all of these symptoms and definitely had that history, but it wasn't actually the artery. It was a cancer. It was a tumor that was compressing on there. So the next, this is Betty. And she was an individual. I remember her first patient visit very, very well. Is she told me she thought she was going crazy because everyone told her it was something, but she never got any source or relief from her symptoms. And this had been happening for 20 years. And so she was 36 years old. She had some C-sections, some thrombocytopenia, just kind of your standard patient going on, but she's been having these recurrent symptoms in regards to low back pain, pelvic pain, everything that we've talked about today. When we scanned her, she had more swelling in her left leg than right, but it was actually on both. And when we had an MRI, and that was actually the MRI that I showed you earlier, you saw how compressed those vessels were. Well, she went in, we were able to do a stenting of that area. She felt better. However, it wasn't 100% fixed in terms of her lower leg symptoms. Her pelvic symptoms improved, but not her lower leg symptoms. And so from there, we were actually able to treat, she had pretty substantial superficial venous disease going on. And so we treated the pelvic vein compression, we treated the superficial venous disease, and she felt so much better. She actually had much more improved quality of life. I think I have on here. Yeah, now she can actually do activities, she can exercise, she can do Pilates. Her life is dramatically different. And then my final patient, Kim, she's one I just saw a couple weeks ago. When she came in, she had debilitating POTS. So she could not stand for long periods of time. tons of pelvic pain, leg pain. And she's an individual that also had the dyspareunia. She had the recurrent cystitis. And I remember talking with her, I was like, wow, we're checking all these boxes here. What was interesting is she was able to go through her hospital system that she worked at, get an MRI that was really inconclusive. The challenge with that is it wasn't our protocol. So there may be, there may not be going on. It's really hard to tell if it's something that we did not order. But she also had pretty substantial superficial venous disease, and her symptoms did not really worsen with wearing compression. And so now we have a decision. Which way do we go? Do we go and try to treat the pelvic symptoms, or do we treat the superficial symptoms? Well, because that compression did not make things worse, that means she's compensating for it. So she decided to treat her superficial veins. She had 8 veins, which were pretty significant, and we went and treated them. And what happened at her 3-month follow-up afterwards is she told me that her POTS completely went away. Her low back pain, her pelvic pain, all that stuff improved. And now she was able to do just normal activities, exercise. I think I have it on here. Yeah, she decided to go fishing, and all these things improved in her life by just treating the superficial venous disease. And this just goes to show that every patient that comes in, yes, they may have these classical signs in these different categories, but it is vitally important to listen to them and see what improves with different types of interventions and guide from there, and go with the thing that we think is going to affect things the most. And so take homes, I have a lot of them on here, but primarily we're looking at pelvic venous disorder as a common and underdiagnosed situation, where we are trying to consider what is going on with some of these very disparate situations. And so hopefully I've been able to give you a very good inclusion criteria of at least to ask that question and rule it out as a possibility of what's going on. So looking at the common femoral vein waveforms, very, very important in terms of telling what's going on proximally, using that SVP classification, as well as just the terminology, not using pelvic congestion syndrome, but pelvic venous disorder is a much more reliable way of describing it. Using compression appropriately, both diagnostically as well as understanding what it can and cannot do. And then treating the obstruction, identifying that and doing the appropriate thing for it. Understanding Phlebolymphedema and how that can be a factor in regards to the long-term diagnosis of these patients. Knowing that undiagnosed and allowing this to progress, the lymphatic system can become involved. And even after stenting and intervention, there's still a lot of stuff that a person will have to do. And then using pelvic floor physical therapy, I think that is absolutely essential post intervention. And then you are the first line of detection. As I've mentioned, you spend more time with that individual than versus anyone else. You hands-on, you can ask good questions, you can see how they respond. And so you get to gather all that information. You get to be the detective. And hopefully this presentation has given you a new way of analyzing things and some new terminology and things to look for to rule this out. Because if you can identify an individual that has this and they get the appropriate care, it can be absolutely life-changing. I want you to be a part of that. And so thank you for participating. I saw it pop up on my screen. I was supposed to say we have some poll questions, but as you can tell, I love talking about this. So I just ran right through everything. So hopefully on the back end, you guys caught that. But thank you for participating. I don't know if we have time for questions.
Thank you so much, Dr. Trock, for that presentation. Yes, if anybody wants to hang out for the questions, we do have just a few. So I think we can take some time here at the end to go ahead and answer them.
Perfect.
All right. So the first question that we received was, do you speak at OBGYN clinics to inform them of MVC services to treat their patients?
We do. We spend a lot of time, as you can tell, I like talking. I like talking about this in particular, but OBGYN is a very interesting one. And it's kind of all over the map in regards to recognition of this. And this is in all things medical. Some people believe, some people don't believe. But I think more and more research is coming out that pelvic venous compression is a real thing, and that when these individuals are caught in an OBGYN clinic, they should at least be referred out for some ultrasound studies to see if that is actually what's going on. I have had individuals where they ended up having a hysterectomy, which all the symptoms were related to pelvic vein compression. And so was that actually needed? Well, who am I to say that? But I do think that that would be a very good thing to rule out prior to having something like that. Even with things like a uterine fibroid or something that's also going on in that region, it'd be a very good idea to rule that out. But yes, we do go and speak with OBGYNs and have that collaborative teamwork as well.
Great. And since you did talk about having multiple pregnancies, someone did ask, would you say that having a C-section would put you at a higher risk?
No, I wouldn't. It's the C-section itself. It's not necessarily the birth of the child, whether it's through C-section or through normal means. It is the act of carrying a human inside of you for 9 to 10 months. That is really what's going on. I didn't get into it, but there's actually a bunch of hormonal things that are going on as well, through progesterone, through relaxin. You think about what relaxin does. It prepares you to give birth, and that is for your ligamentous structures. Well, the collagen aspect of our vessels also respond to that as well. So it's not just the pressure on the vessels, but you're in a state both with the progesterone as well as with the relaxin that can cause those vessels to stretch and dilate. So those are some of the mechanisms going on. And so it's not C-section versus natural birth. It is the act of carrying the child, which worsens after every single pregnancy. And it always baffles me that I do not see more women recommended wearing good compression during pregnancy. I think it is something that is vitally important. And before you tell me, yes, it's hot outside, I get that. I live in San Antonio. Everything I described to you guys today about swelling and varicosities will get worse in the heat. So we have to decide what is the thing we're trying to avoid, the uncomfortableness of wearing compression in the heat or the worsening of these symptoms. So we have to decide where that energy is going to go.
Yes, thank you. And then for patients trying to conceive, what are the things patients need to look out for to be aware of to avoid PVD?
It's a really, really good question. So the first is just be checked for superficial venous disease, because by doing so, if it's a good clinic, they're going to look at your superficial veins, your deep veins, as well as how that blood is flowing into your pelvic region. So that will tell you a lot and give you the nuts and bolts of how to prepare your body for pregnancy, wearing compression, different types of exercise or activity modification. But what could also happen is during that process, you may uncover that you do have pelvic veins being compressed. And then you can have that conversation with the vascular surgeon or interventional radiologist of maybe I should do this before I get pregnant. That's some more newer research coming out. This is our clinic. I'm not going to speak for every other vascular clinic, but it is actually a better idea to get that fixed before pregnancy, so that way you can have that vessel stented, essentially scaffolded, so it's not going to get compressed, to allow for proper flow. Because just what happens in every single pregnancy, there's going to be some compromise of those vessels. Majority of the time, it doesn't cause an issue, but in those individuals that have that going on, that maybe have that variant or some other thing happening, it's a good idea to get that taken care of before the pregnancy happens.
Oh, thank you. And then for compression for PVD, would you say calf length compression would be sufficient?
It matters. When you look at where these vessels exist at, the majority of majority of superficial venous disease actually starts in the upper thigh. And the reason why we don't consider that is because the symptoms develop distal to that. So like the swelling and the discoloration, and typically the varicosities are more seen distal. But the reason it's seen there is because, well, that's the bottom of the barrel in terms of pressure. And also there's less adipose. So there's less fat in that area. So veins are seen easier, but the majority of it actually happens in the upper thigh. And so in terms of treatment of that or prevention of worsening, a thigh high or a pantyhose style would be far superior than a knee high. Now, the one caveat to that is if an individual is getting worsening pelvic compression or pelvic vein symptoms by wearing a thigh high. So if a person is going through that workup, then it's definitely okay to at least be wearing the knee high compression. So that way they get some relief on their venous lymphatic system distally while getting worked up to treat what's going on more proximally.
All right. And a good question to end on is, do you think you're going to take a deeper dive into this subject because it was so informative?
I could definitely do that. As I said, these are some very busy slides. I completely understand that. I know the rules with how to do PowerPoint presentations. I put way too many images and way too many words. I understand that, but there's really no way around this, because if this is not being taught in standard curriculum, whether it is lymphatic, whether it is pelvic floor physical therapy, you need to get all of these things to at least have a baseline grasp, because now you all are going to go out to your clinics and you're going to be thinking differently. You're going to have a different set of glasses to evaluate. And when you go to that patient this afternoon or Monday morning, and they've had 4 pregnancies and they've had this low back pain that's not responding to treatment, and you ask them if they have any varicose veins in their pelvic region, and they say yes, you're going to be doing things absolutely differently. And that makes me very, very happy, because you're going to change that person's life. But yeah, we can definitely talk about that and do this again. I had a
Yes.
great time.
Okay, awesome. Well, thank you, Dr. Truck, for joining us today. And yes, as a reminder, the recording of the webinar will be available on the MOH website. If you're subscribed to the newsletter, I believe you'll also be getting an email about it. So stay tuned, and everybody have a great day.
Thank you guys. Appreciate it.